Welcome to Dermatology Discussions. If you are tuning in today, there is a very good chance you are currently in the trenches prepping for your dermatology board exams or maybe, gearing up for a major clinical rotation.
Yeah, we know exactly where you are sitting right now.
Exactly. You are staring at a massive stack of differential diagnoses, and, well, the mission of this discussion is to help you absolutely master Acrodermatitis Enteropathica, often just called AE.
Right, AE and the broader spectrum of zinc deficiency.
Yeah, we are going to lock in these core concepts so that when you see them on test day or, in the clinic, they're just second nature. But we're going to start by setting a scene.
Oh, perfect.
Imagine an infant brought into your clinic. Their hair is falling out in clumps. Their skin is blistering and kind of crusting away at the seams, particularly around the mouth and hands.
Mm-hmm.
And their gut is completely failing, leading to chronic diarrhea. You might think, you'd probably think you're looking at a severe autoimmune crisis, right?
Right, or a massive, overwhelming systemic infection.
Exactly. But the culprit, it's the absence of a single atomic building block.
Yeah.
How does the deficiency of just one trace mineral cause the entire human body to, well, just fall apart at the seams?
It is, it's a profound mystery when you first encounter it on the wards.
Yeah.
And, to pass your boards, you really need to move beyond just rote memorization of those symptoms.
Yeah, you have to know why it's happening.
Exactly. You have to understand the underlying cellular mechanics. What's really fascinating here is that zinc isn't just, floating around passively.
Right.
It acts as a critical structural cofactor for over 300 different enzymes in the human body. We are talking about the fundamental machinery of life here.
Like DNA polymerase for replicating the genome, right?
Yes, DNA polymerase, RNA polymerase for transcribing proteins, and alkaline phosphatase. When you pull zinc out of the equation, the core assembly lines of cell division, immune function, and tissue repair don't just slow down.
They crash.
Yeah, they grind to an absolute catastrophic halt.
Okay, let's unpack this. Before we pull out the microscope and look at the tissue wreckage, we need to know what the patient actually looks like when they walk through the door.
Right, or when they present in a classic clinical vignette on the exam.
Exactly. So we have a crumbling skin barrier, but it doesn't just happen everywhere all at once, right?
No, it doesn't. For the boards, you must know the classic triad. And I am going to repeat this triad because it is that important for memorization.
Go for it.
It's dermatitis, alopecia, and diarrhea. Again, dermatitis, alopecia, and diarrhea.
So skin, hair, and gut.
Right. You won't always see the complete triad in every single patient, though. The diarrhea, for instance, is it's present in about 80% of cases.
Okay, good to know.
But when you see periorificial and acral dermatitis plus alopecia plus diarrhea in an infant, your brain needs to immediately register that as Acrodermatitis Enteropathica until proven otherwise.
I want to focus on that specific distribution for a second. Acral, meaning, the hands, the feet, the digits. And periorificial, meaning right around the mouth, the eyes, the nose, the anus, and the genitals.
Yeah, the specific spots.
These lesions, they start as symmetrically distributed, sharply demarcated erythematous plaques. But they don't stay as simple red patches, do they?
No, they evolve aggressively. They turn into vesicles, bullae, and pustules, and eventually they become heavily crusted and scaly.
And there's a pathognomonic clinical sign here too, right?
Oh, absolutely.
The ring of crust at the periphery of those erosions. It sounds like, zinc is the mortar in a brick wall.
That's a great way to put it.
Right. Without it, the highest stress areas, those acral and periorificial regions that are constantly exposed to friction and moisture, they just crumble. But why exactly do these specific sites fail first? Like, what makes the mouth and the hands so vulnerable?
Well, the mortar and brick wall is a highly accurate way to visualize this. Those specific areas have the highest rates of epidermal turnover in the entire body.
Oh, because they're always in motion.
Exactly. Because those skin cells are constantly sloughing off and dividing to replace themselves due to that continuous friction and moisture, they demand massive, uninterrupted supplies of zinc.
To run those DNA and RNA polymerases you mentioned earlier.
Spot on. Those areas also naturally have lower baseline zinc levels to begin with compared to other tissues. So when systemic zinc drops, the mortar dries up first in the places that need it most.
Makes total sense. And the fallout isn't just in the skin either.
No, the lack of zinc impairs the rapidly dividing hair matrix keratinocytes too. This causes anagen effluvium, shutting down hair production entirely.
Which gives you that diffuse or patchy alopecia?
Yes, and it often takes out the eyelashes and eyebrows as well.
Wow. Okay, so friction points on the skin fail because they are high turnover factories that have suddenly run out of raw materials.
Mm-hmm.
But earlier we mentioned the gut failing too, causing that severe diarrhea.
Mm-hmm.
Does the intestinal lining have that same high turnover rate? Is it basically the same structural failure, just on the inside?
That is the exact same principle at work. Intestinal epithelial cells are also incredibly rapidly dividing. They turn over every few days.
Right.
Without zinc, those cells cannot regenerate and you get severe villus atrophy. The gut literally cannot maintain its absorptive lining, leading to chronic watery diarrhea.
Which sounds like a terrible paradoxical loop.
It is, because the diarrhea causes even more profound malabsorption of whatever tiny amounts of zinc might actually be left in the diet.
A downward spiral.
Yeah, and the systemic failure just continues from there. You will see dystrophic nails with bowlines, photophobia from the periocular skin and mucosal involvement, and extreme behavioral changes.
Like irritability.
Severe irritability or even profound apathy.
And what about those pustules we mentioned earlier? It seems like having an open, crumbling skin barrier is just an invitation for infection.
Oh, the infections are rampant because zinc is absolutely required for T-cell function and neutrophil chemotaxis.
So their immune system is compromised too.
Yes, these patients have a profound built-in immunodeficiency. Those pustules on the skin are very often secondary superinfections from Candida albicans or Staphylococcus aureus. The body's defense mechanisms are, well, they are entirely paralyzed.
Okay, so we have this severe multi-system presentation, but to really crack a board question, understanding when this presents is just as important as knowing what it looks like.
Oh, timing is everything on the exam.
Right, and the timing requires us to understand how the infant is fed alongside their underlying genetics. Let's look at the actual genetic root of classic AE.
Sure. So inherited acrodermatitis enteropathica is an autosomal recessive disorder. The defect is a loss-of-function mutation in the SLC39A4 gene.
Now, that sits on chromosome AQ24.3, right?
Correct. This gene encodes a zinc transport protein called ZIP4.
ZIP4, got it.
You can think of ZIP4 as like the essential toll booth or molecular pump whose sole job is to move zinc from the intestinal lumen into the enterocytes of the duodenum and jejunum.
Okay, so when the SLC39A4 gene is mutated, the ZIP4 toll booth is basically broken.
Exactly. The infants simply cannot absorb zinc from their diet, no matter how much is actually passing through their digestive tract.
And the timing of the onset is a massive clue for the examiners, right?
Yeah.
It depends entirely on what the infant is eating.
Yes, it really does.
A formula-fed infant actually presents much earlier. Because even though cow's milk contains zinc, the zinc bioavailability is much lower.
Right. The binding proteins in cow's milk hold onto the zinc way too tightly for a human infant's compromised digestive tract to extract it.
So a formula-fed baby with this ZIP4 mutation will crash and develop the triad very quickly.
Yes, within days or weeks.
But an exclusively breastfed infant might not present for weeks or even months later.
The board examiners love testing that timeline. Breast milk contains specialized maternal zinc-binding ligands that facilitate significantly better absorption.
So they act as a workaround.
Yeah, these ligands basically act as a temporary bypass around the defective ZIP4 transporter. It protects the infant for a while.
Wow, that's incredible.
But eventually, as the infant grows and their metabolic zinc requirements exponentially increase, even the highly bioavailable zinc in breast milk isn't enough to sustain them. That is when the protective window closes and the disease fully manifests.
Now, I want to play devil's advocate here for a second.
Yeah.
Wait, if breast milk has such incredible zinc bioavailability and acts as a bypass, why would an exclusively breastfed infant ever get this right out of the gate? We just said breast milk protects them.
Right.
Is there a scenario where the breast milk itself is the actual problem?
This is perhaps the most brilliant distinction that the test raters will throw at you. We have to separate two totally different genetic scenarios.
Okay, I'm listening.
In classic AE, the infant has the genetic defect, the broken ZIP4 transporter. They cannot absorb zinc properly, though breast milk delays the inevitable.
Oh yeah, we covered that.
However, there is a second distinct scenario called maternal transient neonatal zinc deficiency.
Oh, maternal.
Yes. In this case, the infant's genetics are perfectly normal. Their ZIP4 transporters are pristine. They can absorb zinc perfectly fine.
So what's the issue?
The problem is that the mother has a rare autosomal dominant mutation in an entirely different gene, the SLC30A2 gene.
Okay, so the mother is the one walking around with the mutation, acting as the variable in the equation. How does that impact her?
The mother herself is totally asymptomatic. She absorbs zinc from her own diet without issue, but her SLC30A2 mutation impairs her mammary gland's ability to secrete that zinc into her breast milk.
Oh, wow.
So her breast milk is completely devoid of zinc.
Which means the exclusively breastfed, genetically normal infant just starves for zinc.
Exactly, and they develop a severe blistering rash that looks exactly like Acrodermatitis Enteropathica.
Because they are building a brick wall with absolutely no mortar being supplied. Okay, but if the infant's own internal machinery is fine, the fix for this must be incredibly straightforward compared to classic AE.
The fix is wonderfully simple, and that is the core of the board question. Because the infant's own ZIP4 transporter works, you just switch the infant to a zinc-fortified formula or give the baby a direct zinc supplement and they are rapidly cured.
Just like that.
Just like that. Furthermore, it's a transient condition. Once the infant is weaned and eating regular solid food, they will never have a zinc problem again for the rest of their life.
That is vastly different from classic genetic AE, where the patient needs high-dose, lifelong zinc supplementation because their intestinal doorway is permanently broken.
Exactly right.
That is such a crucial board distinction, the infant defect versus the maternal defect. So we have this blistering, crying infant with a crumbling skin barrier. But if we want to confirm what's happening and truly secure the diagnosis, we can't just guess based on the rash.
No, you definitely can't.
We have to take a tiny sample of that skin and look at the cellular wreckage under a microscope. Histopathology is arguably the highest yield area for dermatology boards. What exactly are we seeing down at the microscopic level?
The absolute histologic hallmark you need to burn into your memory is acantholytic dyskeratosis.
Okay.
I will say that term again because it is the linchpin of the pathology questions. Acantholytic dyskeratosis.
Let's break that term down for the listener so it's a concept rather than just a vocabulary word.
Sure. So acantholysis refers to the literal loss of adhesion between the keratinocytes and the skin. Skin cells normally hold hands tightly using structures called desmosomes.
Right.
Without zinc to help stabilize the cell membranes and properly assemble those desmosome connections, the cells just, well, they let go of each other. They round up and detach, floating away from their neighbors.
And what about dyskeratosis?
Dyskeratosis means abnormal, premature cell death or apoptosis. Under the microscope, these detached, dying keratinocytes look distinctly rounded with intensely pink, eosinophilic cytoplasm and very dark, shrunken, pynotic nuclei.
It paints a pretty grim picture.
It does. You will see these dying cells scattered, especially throughout the upper layers of the epidermis. You will also see pale, vacuolated keratinocytes, what we call ballooning degeneration.
Why does that happen?
Because the lack of zinc ruins their lipid membrane integrity, allowing fluid to rush in and cause massive intracellular edema.
Here's where it gets really interesting. Let's think about this logically. If zinc deficiency completely stops DNA synthesis and impairs cell division, how on earth do we see psoriasiform hyperplasia on these biopsies?
Right.
Because psoriasiform hyperplasia means the epidermis is thickened with long, elongated reed ridges dipping down into the dermis. Shouldn't the epidermis just be completely flat and atrophic if the cells are starved and unable to divide?
It's a fantastic paradox to point out, and it highlights a major contradiction you have to reconcile for the exams. You are absolutely right that individual healthy keratinocyte proliferation is severely impaired.
Okay.
That is precisely why you lose the granular layer, a finding called hypogranulosis. It's also why you see perikeratosis.
Let's pause on perikeratosis for a second. Normally, skin cells lose their nucleus before they reach the very top layer, the stratum corneum. It's like packing peanuts being emptied out of a box before the box is sealed
I
shut.
love that analogy.
But without zinc, that differentiation machinery fails, and the cells arrive at the surface still packed full of their nuclei. That's perikeratosis, right? Making the skin barrier weak and scaly.
Exactly the right visualization. So you have this defective perikeratotic surface, but the psoriasiform hyperplasia, the actual thickening of the skin, is a complex, desperate reactive change.
How so?
Well, the skin barrier is severely compromised, and there is rampant, unchecked oxidative stress because zinc-dependent antioxidants like superoxide dismutase and metallothionein are failing.
Okay, so the body's panicking.
Yes. The body senses this catastrophic barrier loss and frantically sends inflammatory signals to thicken the skin to protect itself. So the epidermis reacts with hyperplasia, churning out cells as fast as it can.
But it doesn't work, does it?
No, because those newly rushed cells lack the zinc to actually build strong desmosome connections. So the whole thickened structure just ends up being a fragile acantholytic mess.
Wow. You'll also see alternating perikeratosis and orthokeratosis, which can actually mimic the checkerboard pattern of pityriasis rubricularis, or PRP, but without the follicular plugging.
Yes, very good point.
And of course, we see intrabural pustules, which we mentioned earlier, are very often full of neutrophils reacting to those opportunistic candida superinfections.
Right, and if we connect this to the bigger picture, you have to realize that this specific microscopic pattern, acantholytic dyskeratosis with psoriasiform hyperplasia, hypogranulosis, and perikeratosis in a periorificial or acral distribution, is highly suggestive. But it is not completely exclusive to Acrodermatitis Enteropathica.
Which brings us to the great mimickers. The board examiners are notorious for trying to trap you.
Oh, they love it.
They will give you the classic histology report, acantholytic dyskeratosis, but the clinical vignette will subtly point somewhere else entirely. If you just jump at the biopsy results without reading the rest of the clinical picture, you will get the question wrong.
You must correlate clinically every single time. Let's start with the ultimate mimic, biotinidase deficiency.
Okay.
If you see an infant with a periorificial and acral rash, severe alopecia, and a biopsy showing acantholytic dyskeratosis, your brain immediately screams AE, but keep reading the question carefully.
What are we looking for?
Does the infant also have neurological findings? Things like seizures, profound hypotonia, developmental delay, or hearing loss? And do the laboratory results show a metabolic acidosis and an elevated serum lactate?
And if they do?
If so, it is biotinidase deficiency.
Okay, but why does biotinidase deficiency cause those specific neurological symptoms alongside the rash?
Because biotin is a vital cofactor for several carboxylase enzymes in the body, particularly in the brain and for energy metabolism. When biotinidase is deficient, the body cannot recycle biotin.
So the enzymes just stop working.
Right. The carboxylases fail, leading to a massive buildup of lactic acid and toxic organic acids in the brain, which causes the seizures and hypotonia.
But why the rash?
The skin manifestations look identical to zinc deficiency because the rapidly dividing skin cells also desperately need those carboxylases to synthesize fatty acids for their cell membranes.
Ah, I see.
But crucially, in biotinidase deficiency, their serum zinc level will be completely 100% normal.
That is a classic bait and switch.
Yeah.
Okay, what about the adult mimic? If we see acantholytic dyskeratosis in a 50-year-old, I mean, we aren't thinking about inherited ZIP4 mutations.
Definitely not. That would be necrolytic migratory erythema, or NME, which is the cutaneous manifestation of glucogonoma syndrome.
Glucogonoma syndrome.
The biopsy will show the same superficial epidermal necrosis and acantholytic dyskeratosis. But as you said, this is an older adult. The rash will have a distinct migratory waxing and waning annular pattern, often spreading outward and leaving hyperpigmentation behind.
And what's driving the failure in the skin in glucogonoma?
The patient has a neuroendocrine tumor in the alpha cells of their pancreas that is pumping out massive, unregulated amounts of glucagon.
Glucagon is a catabolic hormone, right?
Exactly. It breaks things down. It drives severe weight loss, new onset diabetes mellitus, and a massive depletion of serum amino acids.
Oh, so the skin is starving again, just for a different reason.
Right. The skin literally starves of amino acids, causing the epidermis to undergo necrosis and peel away. If you check their labs, they will have a wildly elevated serum glucagon level, but their zinc might be totally normal.
Wow. We also have to differentiate this from Derrier disease. Both feature acantholytic dyskeratosis.
Yes, but in dairy disease, the acantholytic dyskeratosis looks a bit different. You see specific specialized forms of dyskeratotic cells called chorons and grains.
And the distribution is different too, right?
Entirely different. It's a seborrheic distribution, affecting the central chest, the upper back, the scalp, and the flexural creases, rather than strictly periorificial.
Mechanistically, what's happening?
Derrier is an autosomal dominant mutation in the ATP2A2 gene, which encodes a calcium pump in the endoplasmic reticulum, not a zinc transporter. So again, their serum zinc is completely normal.
Finally, we can't forget acquired zinc deficiency. The histology is completely identical to genetic AE, but the root cause is environmental or iatrogenic rather than genetic.
Yeah, the tissue looks the same because the cellular starvation is identical. The route to get there is just different.
Give us some examples.
This could be a premature infant on total parenteral nutrition, TPN, where the pharmacy simply forgot to add the trace minerals to the IV bag.
Yikes.
Or it could be an adult with severe alcoholism, anorexia nervosa, or a malabsorptive condition like Crohn's disease, cystic fibrosis, or short bowel syndrome.
Can medications cause it?
Yes, even certain medications can cause it. Penicillamine, for instance, physically chelates the zinc right out of the bloodstream and excretes it, stripping the body of its stores.
So if the exam gives you a patient with acantholytic dyskeratosis, you have to build a mental flowchart. If they have seizures and elevated lactate, it's biotinidase deficiency. If it's an older adult with sudden diabetes and weight loss, it's a glucagonoma. If it's a baby with diarrhea and no neurological deficits, it's AE. If they are on TPN, it's acquired. What's the best way to definitively confirm the zinc deficiency?
To definitively prove the zinc deficiency, you need to check a morning fasting serum zinc level. It will be markedly low, typically less than 50 micrograms per deciliter, with the normal range being 70 to 120.
Why a morning sample specifically?
Because zinc has a diurnal variation, it fluctuates throughout the day.
Okay.
But you should never rely on just the serum zinc level alone. You also want to look for a crucial surrogate marker, a low serum alkaline phosphatase.
So what does this all mean for our lab results? Are there any pitfalls where serum zinc might lie to us?
This raises an important question, and it's a trap many clinicians and test takers fall into. You cannot blindly trust a low serum zinc level without assessing the patient's overall metabolic state.
Why is that?
Roughly 80% of serum zinc is tightly bound to albumin. If your patient has severe hypoalbuminemia, maybe from severe malnutrition, advanced liver disease, or a protein-losing enteropathy, their total measurable serum zinc will read as falsely low simply because the carrier proteins are missing.
But their actual tissue zinc levels might be fine.
Yes, their actual intracellular tissue zinc levels might be perfectly adequate.
And isn't zinc an acute phase reacted as well?
Yes, it is. In times of acute illness, severe physiological stress, or massive inflammation, the body actively and rapidly sequesters zinc out of the bloodstream and hides it inside the liver and tissues.
Oh, like hiding the silver from burglars.
Exactly. This is an evolutionary defense mechanism designed to starve invading bacteria of the trace minerals they need to multiply. So any acute systemic inflammation can give you a falsely low serum zinc.
Which is why the backup marker is so important.
That is exactly why relying on alkaline phosphatase as a stable functional backup indicator is so incredibly vital. If the serum zinc is low, but the alkaline phosphatase is completely normal, you need to rethink your diagnosis and look for hypoalbuminemia or inflammation.
That is incredibly high yield for clinical practice. So we've navigated the pitfalls, we've ruled out the mimickers, we've bypassed the albumin trap, and we've confirmed the diagnosis of Acrodermatitis Enteropathica. How do we pull this patient back from the brink?
For classic genetic AE, the treatment is lifelong oral zinc supplementation. You start with 1 to 3 milligrams per kilogram per day of elemental zinc.
What form does that usually take?
This is usually administered as zinc sulfate, zinc acetate, or zinc gluconate. You titrate that dose upward to maintain normal serum zinc levels and, more importantly, to keep the patient in complete clinical remission.
But you have to adjust it as they grow.
Yeah. Yes. You have to remember, as that infant grows into childhood, or if a female patient eventually becomes pregnant, their metabolic zinc requirements will naturally increase. So the clinician must continuously adjust and increase the dose over the patient's entire lifetime.
And from what I understand, the response to this simple oral supplement is nothing short of miraculous.
It truly is one of the most satisfying treatments in all of medicine. The clinical improvement happens within 24 to 48 hours.
That fast.
Yes, the infant's severe irritability and incessant crying fade almost immediately. The chronic diarrhea stops within a day. The blistering, crusted rash will fully resolve and heal in just 1 to 2 weeks, and the alopecia will completely reverse, with hair regrowing in 2 to 4 weeks.
Microscopically.
Under the microscope, the cellular repair is just as fast. The acantholysis stops because the desmosomes instantly reassemble. The granular layer magically reappears, the perikeratosis clears up, and the inflammatory infiltrate vanishes.
It's an incredible journey from total systemic collapse back to perfect health. We've covered the triad of dermatitis, alopecia, and diarrhea. We've explored the genetics of the ZIP4 transporter and the nuances of the maternal SLC30A2 mutation. We visualized the histopathological wreckage of acantholytic dyskeratosis. We navigated the devious mimickers like biotinidase and glucagonoma, and we locked in the critical lab pearls regarding albumin and alkaline phosphatase.
If you can hold all of those interconnected mechanisms in your mind, you are going to be in excellent shape for the boards and for your patients. And I'd like you to consider this final thought as you go back to your studying.
Lay that on us.
Think about that rapid 24-hour reversal of this severe disease the moment you provide a simple oral zinc supplement. It perfectly illustrates the sheer, breathtaking speed and efficiency of human cellular machinery.
It really does.
It is a powerful reminder that sometimes the most dramatic, terrifying, destructive clinical presentations, an infant whose skin is sloughing off, losing their hair, failing to thrive, aren't caused by a vicious pathogen or an unstoppable malignancy. It is simply the absence of a single atomic building block. You put the mortar back in the brick wall, and the entire magnificent structure instantly rebuilds itself.
Like, subscribe, and share for more content like this.